This is Encrypted Ambition, a podcast about the builders rewriting the rules. Join Petronella Technology Group as we decode the ideas, challenges, and momentum behind tomorrow's business, technology, and leadership breakthroughs.
What you do?
Sure. I'm Dave Saunders. I'm a former Chief Technology Officer of Galen Robotics, and now I'm working with another surgical robotics company that's kind of in a stealth mode. And I've got about 30 years worth of internet technology experience. That began from the very early days before the internet was public. I've developed some early internet protocols that unfortunately are no longer in use anymore. Maybe it's fortunate. And also worked on high density access concentration in the days when dial-up was sexy and cool. And my group, I was also a research manager at Lucent Bell Labs, and my group invented the first commercial Wi-Fi hotspot, which was the little spaceship-looking Apple Airport, if you remember that thing.
I do.
We actually built that in my group
Wow.
at Lucent Bell Labs. So, I've been around different hardware and software technologies for a long time. Certainly worked with a lot of the early explorers into internet security issues.
Amazing.
So it's certainly been part of my DNA for a really long time, and most recently, about the past 10 years, I've been working on commercializing some different surgical robotic technologies. Took one through successful FDA clearance about 2 years ago. And I've been, for the past 10 years, working in close relationship with Johns Hopkins University on advancing surgical robotics and taking that into kind of the next generation of computer vision and AI, utilizing those things. And of course, all of that is affected by cybersecurity, which is a good thing. It's not an afterthought, but it's something that you really do think about as an architecture from the get-go.
Amazing. And from my understanding, Galen developed the concept of digital surgery as a service. Can you explain how compliance considerations went into developing a surgical robot?
Yeah, it's surgical robots are interesting because, of course, they appear to come in many flavors, but really, in essence, you've got a master system component, and then it's driving the controls for actuators and sensors and all of that to give you whatever that robotic function is. That creates a number of potential security issues. So not the least of which is just your basic man-in-the-middle risk. The master of your surgical robot is always disconnected by millimeters or feet or miles between the slave components that it's intended to be operating and responding to. And so I think that's probably one of your first and foremost issues in terms of just making sure that the data that you send and receive between those components is authentic and is not subject to any sort of injection risks. And I think that's kind of like your first and biggest issue, because obviously that's going to be the first thing that is potentially going to put a patient at risk. HIPAA compliance and patient privacy, those are also very important. But when you're dealing with a surgical robot, my first concern is to make sure that the patient is never put at physical risk of harm through the use of the system. And that, everything is a risk-based model. And that risk, I believe, is far more important than HIPAA compliance. Those are important too, but my patient isn't going to literally live and die based on HIPAA compliance, right? So I think that's where your first model comes from. Then, sorry. Then your kind of your next areas then are, how plugged into the rest of your hospital administration system are you? Are you plugged into Epic? Are you actually pulling a patient record, or are you aware of who the patient is and associating your logs just for maintenance or follow-up reasons? Do we want to have any sort of association between the operation of the surgical robot and a patient record? And if the answer there is yes, then now we start to have some HIPAA compliance issues where I want to de-anonymize my data, and I want to make sure that any individual record is not going to expose patient privacy issues, and those are a challenge as well. A lot of surgical robots today, and there's about 170 of them on the market, are not actually reading patient data directly, and so they tend to be islands. So that kind of patient privacy is not necessarily an issue today. But when we look forward in terms of where the technology is going, when I start to do things like, for example, for head and neck surgery, there is technology on deck for future applications where I might be taking the CT scan in, building a 3D model, and then having the robot actually look through the surgical microscope and trying to see what the surgeon sees. And now I have direct access to patient data, right? So I want to make sure that I'm not putting risky issues in terms of attaching patient records now to navigation data. What's the serial number of
Right.
their hearing implant. Now I do have the potential of really breaching a lot of private HIPAA compliance issues and things like that in terms of patient privacy. So I would say their patient privacy issues are probably not as much of a risk with most of the surgical robots on the market today, but certainly as we try to bring in um, next generation features involving computer vision, involving machine learning, those issues do become more of an issue because just for example, probably the hottest topic when it comes to surgical robotics is something called a digital twin, where I want to be able to take in patient model data, which is going to be associated with their records in Epic in some way. And I'm going to associate that with real-time telemetry data, which could be the visualization system from my endoscope cameras, navigation data that is automatically calibrated and registered to patient CT models. So where this is going in the future, yeah, we've got a really, really tight coupling between those patient records and the operation of the robot. So those things do become more and more of an issue over time, which just means that the security teams are going to have even more of a mess on their hands. I mean, I know security teams are already overburdened, just allowing hospitals to operate on the internet in general. But I think some of those issues are going to become certainly more forefront over time, because going back to what I was saying originally, um, you know, patient safety when I've got a robot that's effectively armed with a sharp, pointy device, a scalpel, a cauterization tool, that thing could do a substantial amount of harm to the patient in the event of data being manipulated, man in the middle telemetry, all of those sorts of things. So those become more and more of a risk the more I tie features in that become patient specific, and we start to allow the surgical robot to begin to have more autonomy. I mean, today it's really just the tip of the iceberg. You look at like your average like pedicle screw driving robot, um, it's not really doing that much in terms of autonomy. It's positioning a cannulated instrument adapter, and the surgeon is still, you know, twisting the handle on the drill. They're still driving the screw, right? And so there still is a substantial amount of of surgeon autonomy that's driving even the most automated of surgical robots out there, but it's not going to be that way forever. And it's not even going to be that way for the next 5 to 10 years.
What type of like data does, or like EMR, EHR, PHR, like what type of data does these robots collect, or do they require to perform the surgeries or functions they're designed to do?
Today it's very limited. So if we take like obviously the 800-pound gorilla in the room, a big Da Vinci style system, this is a teleoperated robot. It's got, 4 or 5 laparoscopic rods inserted into the abdomen of the patient, and there is a surgeon sitting at a console, and they're remote controlling those rods. Uh, the amount of patient data that's required for that procedure in terms of what the robot needs to know is almost nothing today. And that's because the robot is being driven by the surgeon. It's a remote. It's basically just keep in mind that the Da Vinci was invented based on DARPA research that was originally designed to remote manipulate radioactive materials and allow the operator to be safely away from the radioactive um, material, right?
Right.
So that's the concept there. It's not that the Da Vinci's doing anything autonomously. It's simply extending the hands of the surgeon into the patient's abdomen, giving them excellent vision, giving them really incredible dexterity, but it's soft tissue surgery. So there's really very little that it needs to know today about the patient. Now, one example of a publicly demonstrated piece of technology that is not commercially available in any way um, is augmented reality for the visualization system of a Da Vinci or a Da Vinci type robot, where I can get false colors to show me that I'm now touching the actual patient organ. And if I push on it, I can actually get like a color map showing me how hard I'm pushing on it. Incredible, incredible feedback. Now, does that require patient data? No, it doesn't. It's all done in real time, and so it's all very it's all very detached from the patient record information. Now, can that information be uploaded into the patient record for use? Absolutely. I just recently had I had a colonoscopy, right? And in my EHR, I've got a bunch of snapshots, great for 8x12s, and of my insides, right? And so that's now part of my record. Well, at some point, it makes complete sense that you would be doing the same thing with a surgical robot, where I'm going to be taking snapshots of this is the position of your pedicle screw. This is the position that we decided. This is where digital twins become very helpful. This is the planned position of your knee implant, and this is the actual position based on bone data, based on the fact that the registered camera and navigation system can actually see your bone. It can see where the implant went. and we are only 1% off of the intended original plan. We're definitely moving into a situation where we will actually be placing that kind of data into the EHR, and it makes complete sense to do so. But in terms of like the raw operation of the robot, it's pretty limited in terms of how much patient record information the robot needs to operate.
Right.
Yeah.
Yeah, so you would think that attackers, right, like hackers, would have some moral standing to not attack a hospital or an emergency, like care facility.
Mhm.
But unfortunately, that happened not that long ago,
Yep.
and it happens pretty regularly.
Big hospital
Ironically,
in Boston.
yep,
Horrible, horrible
yep.
DDoS. Yep.
Unfortunately, my dad was in on a ventilator when the CrowdStrike event happened, and so
Yep.
curious to see how you guys are kind of distancing yourselves from probabilities that could attack
Yeah.
hospitals or institutions. How do you assure that your
Well,
device remains functional and
right. Very, very important. So first and foremost, as of right now, if I asked a hospital for a live internet connection for a surgical robot that I'm installing during the procedure, I'm going to get a hell no from the hospital. There's no chance. Now, I still need that for occasional updates. I want to update my SAS data for maintenance prediction and things like that, right? So there is that issue of vulnerability that's not intraoperative, right? So that will be a risk in the future. But today, yeah, I'm going to be connecting my system um, to the internet to do SAS uploads and things like that. So that's when I'm most vulnerable right now. So like I was saying earlier, my first concern, and this is where my paranoia comes in, just because of the hackers I've known and black hats versus white hats.
sure.
Man in the middle is, as far as I'm concerned, the thing that actually keeps me up at night, right? And so when I'm making that connection, I want to make sure that I'm not getting any patch data to the operating system that did not come authentically from my company. And so I have a series of layered MD5 fingerprints and some other techniques to validate each of the subsystems in my control mechanism. So our software is kind of bifurcated between two different computers that talk to each other inside of the system. And then there's another controller as well. So there's a few different computing systems within our robot alone that actually talk to each other. And so each of them is authenticating their own software to make sure that if there is a patch, it has to be uh, you know, uh, heavily authenticated. Um, and any signs that I don't have an authentic load automatically shut me down. Um, Now, that being said, I do want my robot used in research settings. So, there are ways that the robot can be put into a not for human use. The screen is plastered with "I'm not operating on a person," that sort of thing. And so then students do have a documented ability to take over the robot controls, but that is system software that's being run on a research platform, and they don't have the ability to override this to actually patch the software on the robot itself. So there are mechanisms that allow you to completely hijack the system. But if you do that, if as you're saying, like if there was a bad actor scenario, that override would be detected by kind of like the display computer, and it would immediately go into a you're not operating mode. There's all kinds of like, klaxons and
Yeah, yeah.
red overlays that would indicate that we are in research mode only. And if that ever happened in an OR, the surgeons are trained that, yeah, okay, there's a problem, and I would not use the system to operate if I'm not getting we're in operating mode. So those elements are pretty well protected and preserved. Now, all of that data, so even my SAS data, my operating logs and things like that, those are going up encrypted. They're going up signed. So any data that's being moved back and forth between the system and my SAS servers is also authenticated, de-anonymized, anonymized. I guess you don't
Yeah, yeah.
de-anonymize it, so it's anonymizing it, and uh, and signed. So encrypted, signed, anonymized. All of that is going through a default process when it's being uploaded to anywhere outside of the hospital. So if I'm taking any of that data outside of the hospital, I can't have any patient record information ever. I don't think any of the agreements that I've done with hospitals would allow me to, even for research purposes, have the name of the patient, and I have no need for it anyway. So
Sure.
all of that is stripped if it goes up into the SAS server, and that is explained in detail in the operating agreement that I have with the hospital.
And you may not be able to answer this. I also don't want to get too much of your secret sauce, but as AI is evolving, how do you see the future of surgical robotics advancing?
So yeah, so there's a couple different areas there. One, I think it gives me some really interesting opportunities um for cybersecurity protection, right? One of those just being watching for ticks and blips in latency. Man in the middle. I'm just going to keep saying that that's where my paranoia lies. If I'm able to actually watch what my back and forth ping times are, I can see where my blips are, and so that's digital triage opportunities for me for a cybersecurity standpoint. And so just being able to monitor the data flow and say, does this look normal? Does this look like just a general back and forth buzz? I mean, my updates are like every 5 milliseconds and things like that. And if there is a hiccup, I should be able to have an AI system that's in tune enough with the other subsystems that it could say, oh, that was just a hiccup on the disk drive or whatever, right? And so the AI should be able to account for most hiccups in latency and be able to associate them with some system operation that actually is normal and it's okay. And so that means that now I only have maybe, two or three, hopefully, anomalies that I want to go and look at. And if they actually are, false positives, then I'm going to take those out. Um, Next level up from a clinical standpoint, and this is, of course, where everybody cares about cybersecurity, but nobody's going to buy my product unless it has clinical relevance, right? So the AI that is most interesting to the customers is where we're going to start doing things like augmented reality. We're going to use things like AI to do patient registration. And what I mean by that is visualization systems, where um, I'm going to uh, look at any patient imaging data that I might have in the EHR, and I'm going to use that to either authenticate and make sure that I'm operating on the right patient. With bones, that's obviously a lot easier. So, for example, I'm about to open up a patient behind the ear for a mastoidectomy, a pretty significant drilling process. If I've got a CT scan of the patient's skull, I should, by today, with today's technology, couldn't do this 10, 15 years ago, but with today's technology, just based on what I can see through the surgical microscope, which is a stereo microscope, I should be able to very quickly find anatomical landmarks and match up what I can now see of the actual IRL patient and match that up to the CT scan that's in the EHR. That's great because not only is that potentially valuable for future navigation and augmented reality applications, but if I can't get a match, I'm going to scream bloody murder to the surgeon and say, there's something wrong here. Are, are we operating on the wrong side of the head? Is this the correct patient? So I think that gives us a really interesting opportunity to really make sure that we don't have those 1 in 1,000 or even 1 in 10,000 or 1 in 100,000. That's a lotto number that nobody wants to win, right?
Yeah.
So it really doesn't even matter what the error rate is for those surgical errors. Nobody wants to be the one. And if I can do such a simple thing as have a machine learning algorithm just take any patient data that I have and correlate it to what is actually happening in real time and say, wait, that's not an appendix.
Yeah. Something obvious.
Are we in the right part of the body? Are we doing the surgery that, oh, by the way, I have a copy of the patient's surgical order. You're about to remove the prostate of a patient that was in here for a colostomy, right? The potential for machine learning to actually double check the procedure and just go, hey, I know what your camera's pointing at. Why are you about to sever this person's prostate when we're supposed to be working on their colon to remove diverticulitis or, something like that, right?
Interesting.
That's a really interesting opportunity. And that obviously is going to require me to either have real-time access to the EHR or I'm going to want to be able to download it temporarily before I start the procedure. So there's some really cool opportunities for just ensuring patient safety in the future when it comes to AI applications and surgical robotics. I think that's pretty cool all by itself. There are also opportunities for advanced medical procedures. And the one that I've been studying the most recently is middle ear surgery. And so but these challenges apply all over the body. So when I'm going to do a middle ear procedure, I'm going to drill about 1.5 inches diagonally through the hardest bone in the human body, which is your skull right behind the ear. This is the mastoid. And not only is it 60 to 90 minutes of drilling with an 80,000 RPM Dremel tool.
Oh my God.
It's gruesome.
That's terrible.
The punchline to this part of the procedure is that embedded in the bone are two facial nerves, and you cannot see them until you've exposed them. And if you nick one, your patient will have they're not going to die, but they will have an irreparable injury. Either they will lose control of one side of their face, or they will lose pretty much all sense of taste and smell for like salt and savory items. So no more chocolate, red wine, or meat.
Oh my God.
And that sucks, right?
Yeah, totally.
And so this is honestly, even though you're about to operate on the middle ear, which is an incredibly delicate and tiny organ, the most grueling part of that surgery is the first 60 to 90 minutes. I'm holding that drill in a white knuckle death grip, looking for weird little not so standardized landmarks that will tell me that I'm really close and I think this facial nerve is here and I think this facial nerve is here. Well, in research, we have demonstrated that by taking the full head CT scan and giving it to a neural net, the neural net is able to segment all of the anatomical structures in the middle ear, all of the bones, and it's even able to pick out the little ghost trails of the two facial nerves that are embedded in the mastoid. So what can I do now? Well, If I have that 80,000 RPM Dremel tool being held in the hand of a surgical robot, I open the patient's skin up behind the ear. I've got now enough bone exposed that I should be able to map the CT scan, a 3D conversion of the CT scan,
Right.
to the actual patient bone. Boom, I now have effective navigation. Now I register the tip of the drill, which doesn't require, old school touching a bunch of fiducials. I can see the tip of the drill with a 4K surgical microscope. So with OpenCV and a neural net, I can now register the tip of that drill. From this point, it's all I have to do is watch the kinematics of the robot relative to the patient bone. So now I know where those embedded nerves are, even though the surgeon can't see them. So this is super cool. So now, even though the surgeon might be their hand may still be literally on the hand of the drill, but the robot is holding the drill at the same time. Now I allow the surgeon to do the drilling. They can go as fast as slow as they want, but because I know where those facial nerves are, I can create virtual keep out zones, virtual barriers, and I can now protect the patient nerves by, haptics. I can, give you a little shutter on the drill. If you move too close to where I know that nerve happens to be, I can just stop you entirely if you're about to hit the bone that would have exposed it. And so now I can very safely guide the surgeon to just do their drilling, but completely keep them away from those critical anatomical structures. Super, super cool. And that has the potential of increasing the speed of those surgeries. In fact, in research, we've taken 60 to 90 minutes of drill time down to about 15 to 20 minutes.
Wow.
So we're potentially cutting an entire hour off of OR time. That the hospital might as well throw you a parade for that much savings, right? And they would still save money. And so that's a big deal right there. But that also now means that patients that might have had some bone abnormalities or the nerves in a weird place, and I'm just having a hell of a time doing that drill through. There are a lot of patients that are turned away from these kinds of so-called routine surgeries simply because the approach or some abnormality of the patient themselves they just make them a bad candidate for the surgery. And so we could improve the number of potential candidates for these surgeries. And because we're now also creating these guardrails to make these ergonomically and just exhausting, huge I mean, imagine doing, this kind of no mulligan drill through. Not all surgeons can do that. Not all
Right.
surgeons are qualified to do neurotology. It's just the burden is significant. And yet, I will go out on a limb and say every single attending surgeon out there in the field of otolaryngology has at least been trained. They know functionally what to do a middle ear surgery. Just not all of them have that, super, super crazy steady hands that, the rock star surgeons have and those sorts of things. The robot has the potential of moving those people over on the other side of the bell curve and allowing them to utilize all of that training and know-how and intelligence that they have, but now give them the magic hands.
Wow.
Through virtual barriers and through things like that. And so that means more surgeons that are able to do these procedures. We've already seen this just because of the mechanical advantages of operating a Da Vinci or a similar teleoperated robot. We're already seeing those advantages right there, where literally an order, if not 2 orders of magnitude, more abdominal surgeons are able to do minimally invasive prostatectomies and minimally invasive hysterectomies because of the Da Vinci. That's incredible. And we're talking we're talking, two decimal point shifts in terms of the number of surgeons that are able to provide that standard of care to patients. That's huge. And if you can do that all over the surgical field by providing computer vision, by providing, HUD guidance through the visualization systems, through the technologies that they're already familiar with, where basically the AI is your co-pilot, right? Maybe co-pilot is a bad word just because kind of Microsoft has soured that for a lot of people, but still, that's that's what it is, right? You've got the AI sitting over your shoulder. The surgeon's still the one that goes to jail if something goes really, really wrong. The surgeon's still the one that gets sued. So let them be in control, but use AI to give them better tools or to make the tools that they already use, make them better. And I think that is the true clinical advantage of AI today in terms of clinical applications. But on the cybersecurity front, it's no different. All of your IT people at the hospitals, they're overburdened. They've got
Totally.
way too much to do. If you can do digital triage on your security profiles and have them, burp up, oh, here's an abnormal log. Tell me if this is a false positive or not. Have them burp that stuff up. You're taking the mundane crap that nobody ever wanted to do in the first place. That's what computers are good at. Let them do that sort of thing. And we see a parallel of that in radiology. In fact, a very close friend of mine recently found a tumor in her chest that initially a human radiologist had said, I don't see anything wrong, but we just acquired an AI system that couples our with our mammogram scanner. Would you mind if we ran it through that? They don't have it set up as a standard of care yet. And they ran it through the AI, and it came back and said, "Look at this shadow here. This is something." And so then they went back to her with a more refined instrument, did a close-up sonogram, and sure enough, they found something that the AI had found.
Wow.
So at some point, this needs to become standard of care. When you're standing at a mammogram machine, the very first thing it should do is go through, the a simple triage sorter. 99% guaranteed, you're totally fine. Put on your shirt, go home. You look okay. I've got like a 95% confidence. We'll put it on the stack for the radiologist to double check. Here's a couple little things that I think I found. Or the other side of the bell curve, do not let this person go home. And if you can have that done in milliseconds or even seconds, integer seconds, um, you're providing a better standard of care for the patients, and you're relieving burden on the human beings that right now are stuck with, okay, at least they're in the EHR system, so they're not literal stacks of radiology scans, but they still have just so much to go through, and most of it is fine. They're routine mammograms. There's no risk there. Let AI sort those things out. I still feel that a human being, at least for the foreseeable future, should scan through those things manually as well and double check them and sign them off. But let's let the sorting hat do its job and put those things in the right piles and prioritize where the work should be. And those are the kinds of things that I think you can do from a cybersecurity standpoint. And I think those are the kinds of things that you can do from a clinical standpoint that are going to give you the most bang for your buck and give you a real return of value for the hospitals, for the patients, for the payers, for the doctors. I mean, all of the stakeholders benefit when you apply AI in those areas in that model of paradigm. And that's how I see it.
Amazing. I know we're about 40 minutes in. I don't want to like clip you at your knees.
No worries.
I also don't want to like I want to be respectful of your time. I just want to make sure you don't have like a hard stop or something.
I'm good right now. Yep.
Oh, okay, okay. I guess I got one more question. And
Sure.
as a film guy, films like iRobot, Terminator, things like that, you think of the Skynet, right? Of you have a lot of people that are less trusting in
Mhm.
technology. Have you encountered resistance using the Da Vinci? How do you communicate? How do you ease patients and let them know that this technology is safe?
Yeah.
And how do you build rapport with patients before going into surgery?
Today, it's actually not a problem. In fact, I had spoken to hospital CFOs who are buying surgical robots because they are losing business without them.
Wow.
It is the weirdest thing I've ever seen. I mean, imagine going to a hospital being told that you need surgery and saying, "Well, what brand of scalpel do you use?"
Yeah.
And if you don't get the answer you like, you go, "Well, I'm going to go to the hospital down the street because they use XYZ brand of scalpel," right? That's effectively what is driving a lot of surgical robotic utilization today. Now, I still believe that there's an extreme value. I mean, I know some incredible surgeons that use, they don't pick and choose when to use the Da Vinci and when not to. They use it as their standard of care, and they are just magicians with the Da Vinci. It's incredible to watch them do their work. And so I believe that the more training and the more experience you have with surgical robotics, why would let me give you a quick parallel example.
Sure.
If you ever have LASIK, okay, LASIK is relatively new technology. It is a surgical robot, okay? It is tracking your eye and it's shooting a little laser to give you scars. Now, what existed before LASIK? A procedure called PRK, where a surgeon had a hand-drawn map of your eye and they had a little trajectory plan of where they were going to make incisions on your eye to do exactly what LASIK does, right? The scarring caused by those incisions from the laser burns reshapes your eye, and that's what causes your vision to change with LASIK. Well, that used to be done with a diamond tip scalpel held in the hand of an ophthalmological surgeon. So let me give you a hypothetical question. Let's say you need to have your vision improved. Are you going to go with LASIK, which is a surgical robot, or are you going to say, no, 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 I need old school. Give me a surgeon with a scalpel in their hand and let them poke me in the eye with that thing? I'll tell you, I know exactly what my decision's going
Yeah,
to be.
totally. Same,
There,
same.
I can't imagine what parallel universe I would be going, I don't know, I need to go old school. Give me that diamond tip scalpel. And that is becoming the market demand for things. Now, let me give you another example. I hope that you are never unfortunate enough that you are told by a doctor that, hey, I'm sorry, but we got to take your prostate out. If that was ever to happen, you have three options. The first is old school open surgery. They open you up like a frog in biology class, man. It is gruesome. You lose 8 units of blood, and there is no open procedure for a prostatectomy that will protect the nerve that runs up through the middle of the prostate, which
Oh
means
no.
that when you're done with that prostatectomy, a certain malfunction that you would probably like to have preserved will
Yeah.
never happen again.
Oh.
Okay. Option number two is manual laparoscopic surgery. And that was invented. The manual laparoscopic prostatectomy was invented at Johns Hopkins University or School of Medicine. And uh, there are certainly surgeons that can do that as a manual laparoscopic procedure, but the number of surgeons actually is in the dozens. We're on a planet with 8 billion people, and there are probably dozens of surgeons that will do a manual nerve sparing laparoscopic surgery. In the state of California alone, the last time I looked into this, there were probably 3,000 surgeons that could do the laparoscopic nerve sparing prostatectomy with the Da Vinci or that kind of teleoperated robot. So that means that you've got 2 orders of magnitude more surgeons that can do the nerve sparing technique as long as they're doing it with the robot. compared to manual laparoscopic surgery. So here's the rub. Sometimes you see these newspaper articles and they say, oh, there was this longitudinal study and it says that using the surgical robot for this procedure is only as good as a laparoscopic surgeon doing it manually. Okay, well, that's an interesting data point. But if there are 2 orders of magnitude more surgeons that can do that procedure, well, then that means I'm not waiting 9 months to have in fact, I had a friend pass away on the waiting list because this was over a decade ago. He was terrified of having the Da Vinci used for his prostatectomy. And so he waited on a waiting list for a manual prostatectomy and died on the waiting list.
Wow, that's terrible.
So that's how I see the opportunity for surgical robotics, is that even if it is only as good as the best practitioners in the field that are out there today, if I can take surgeons that are fully trained, they know exactly what they're supposed to do, and they simply operate a robot as the extension of their hands, and they get consistent results day in, day out, every single procedure of the day, what's my downside? And I think, to me, that is really important. And what I think is gratifying is that from the discussions I've had with patients, with surgeons, with hospital administrators, with the payors, they seem to agree that right now that's a very significant, not only market driver, but it's also a huge benefit. If I know that at my hospital, simply by buying a $2 million Da Vinci, I can now take my entire urology department and give them all superpowers, that's a huge, huge win. If also from a marketing standpoint, that means that I'm not losing patients from Good Sam in San Jose to, Stanford, up the road, that's a valuable purchase that I can justify the purchase just by saying I'm not losing patients. Because at the end of the day, I mean, this is we have to have revenue to keep the hospital open.
Sure.
So losing patients just because I don't have the latest tool that's a significant burden as well. That's a financial issue. So right now, with the current state of the surgical robotic market, the acceptance of surgical robotics is pretty good. And so where that goes in terms of, like, if we start allowing AI to perform any kind of autonomous function with that surgical robot, that might change. That perception might change. Right now, to my knowledge, 170 robots in the market. The FDA has not approved a single application in AI that is directly affecting the surgery. There are lots of opportunities. In fact, there's over 800 AI applications that have been approved by the FDA. 0 of them utilize LLMs of any kind, but the 800 are probably 80 to 90% of them are diagnostic, right? And so that's certainly where the sweet spot is in terms of getting approval and applying those today. But there's going to become a point where, I'm going to be able to demonstrate clinical benefit, and I've described some of those to you already, where by bringing in AI, I'm going to be able to demonstrate real clinical benefits working with a surgeon. But yes, when I lift up the hood, the veil is pulled back, and yes, the AI is in fact taking away a little bit of the thinking process. The AI is definitely relieving the surgeon from some decisions that they would otherwise have to make on their own. And you could argue that is taking away surgeon autonomy. That's when the FDA is going to really start to scrutinize those applications. Nobody's tried it yet. It's coming. They're in research, but they haven't been commercially approved. When that starts to happen, the first one to do it, unless they're an idiot, is going to just like have the PR blitz of a lifetime, because whoever is the first one to get approved has cut ice for everybody else. with the FDA. So it's a big deal when that first approval comes. But with that massive fanfare and screaming, that you were the first from the mountains, certainly there are going to be some patients that are going to be, and surgeons that are going to be a little apprehensive and go, I'm not sure, right? That's going to happen. But I don't know. The market's a weird thing. I mean, look how many people seem to be willing to sit back and say, hey, Chat GTP, would you please write my legal brief and
Yeah.
include, so, the trust might not be warranted, but there's certainly, I think there's certainly evidence out there that people are willing to trust AIs, and that therefore puts the burden on people like us to make sure that whatever we're implementing, by golly, that sucker had better be handcuffed to the wall and make sure that it cannot go Skynet and
Yeah.
it cannot go off in the wrong direction. Because when it comes to surgical robotics, I mean, what are some of the comparisons of your average neural net? I mean, at best, I've got a 6-year-old's brain at a highly specialized function. Yes, it can process more data than any human being, but its decision capabilities are still incredibly narrow. And yet, I'm putting a weapon in its hand and I'm asking it to do something effectively, even 20% autonomous, 80% surgeon control. I'm still putting some trust into a robot holding a weapon.
Right.
And that is the perspective of the folks that I've spoken to at the FDA. That's how they're looking at it. And so whoever tries to go through that door first, yeah, they gotta they got some work on their hands. Um, but it's going to happen. And it's going to happen not only because the potential clinical benefits coming in the future, they're too much to pass up. It's not just about like, oh my gosh, I'm going to nerd out over putting AI into a surgical robot. It's not that. The potential clinical benefits are real. The potential time savings, even though the surgeon is still there operating side by side, co-pilot, whatever you want to call it. Um, I'm I, I'm already looking at potential clinical applications where I could cut a literal hour off of OR time. That's huge. You can't pass up an opportunity like that. And so those are big deals, and we won't be able to hold that dam back for forever. So as those applications get developed, yeah, I got to make damn sure that the AI is only doing what it's allowed to do and what it's supposed to do, because we can't predict every outcome. So it needs to at least have enough pseudo cognition to know when it's about to be asked to do something that it shouldn't be doing. But then where does that I know we haven't talked about this, and we're about to click on an hour, and I don't want to take up too much of your time.
My next appointment's at 10, so I've got an hour.
So, so, you know, uh, where's that processing happen? Do I put, a fleet of NVIDIA? I don't know what's going to be the hot card, 3 years from now,
Yeah.
the 5090, the 6090.
Yeah.
Do I put that in a small Nakoda reactor, beside my surgical robot, and do all of this based on edge computing? Which means I now have to have an architecture for downloading all of my latest learning data from the cloud, where I'm doing like aggregate processing. I'm aggregating all of the surgical robots, everything that they've learned, everything that they've encountered. I'm pulling that up into the cloud. I'm doing processing up there. I'm vetting it, and then I'm pushing it down to the edge, because the hospitals, I hope, never allow an active internet connection anytime soon. So I can't do my processing in the cloud. Do I want to, even if I could? So I have to make those decisions, like how much is it really going to cost to have sufficient edge computing in every device? And do I want it to learn locally, or do I only want it to do what it's already vetted to be allowed to do, and take edge cases, take false positive, false negatives, whatever, push those up to the cloud, allow them to be processed and vetted up there by a team of computer and data scientists. And then once they've vetted those new learning models, push those down to all of the computers. That needs to be figured out, right? And then at some point, we get into, the robot. What's the holy grail that we're really trying to achieve here, right? We want the autonomous surgical robot from the movie Prometheus, right? I've got an alien in my abdomen. I need an emergency C-section, right? And it just knows what to do. And you need that. I mean, at some point, Moonbase Alpha and Mars Colony, if that ever happens. I'm a little skeptic of the Mars thing, but at some point we're going to be in space, right? And I don't know if you remember, there was a surgeon in the Antarctic, the only surgeon in the Antarctic at the time, who had a burst appendix. Well, who's going to do that surgery? Answer, he took out his own appendix.
Oh my God.
And you can find pictures of this. It's pretty wild. So when you have, these orbital platforms, you've got Moonbase, we send a bunch of people to Europa, whatever. It's going to happen someday, right? So how many surgeons are going to be on board? Those spacecraft, how many of them are going to be on the remote colonies? And what happens if something happens to them? What happens if there's a crisis and you need more than one surgeon because you've got, 10 people that all need life-saving care? We've got to have surgical robots just to take care of that. We've got 8 billion people. I don't know if you've ever looked into what surgery is like for rural India or rural China, but it ain't pretty. We need telorobots in those locations just to allow the surgeon that is in Shanghai to operate on somebody that's in a less developed area, Guangzhou or something like that, right? Same thing for India. We need that to help those surgeons, but at some point we're over 1.8 billion people in India, right? At some point, we need autonomous surgeons to do the cookie cutter surgeries, right? If I've got an appendix burst, at some point, we really would benefit from having a surgical robot in the back room of Walgreens. This scenario sounds scary, but but really, if you had that happen, I mean, I'm here in. Oh, good. Sorry.
No.
I'm here by Johns Hopkins. I know what the ERs look like here. I've talked to ER doctors. My wife had an injury a while back, and 6 hours of sitting there with a compound fracture is not time that anybody wants to spend. And if you've got triage robots that can do certain cookie cutter tasks, now, biology is not standardized. Human beings do not fit into easy patterns, unfortunately, but there are certain things you can do. You could probably build a robot that can set a bone. And if it's a femur, you want to do that as fast as you can, or your patient will die. You can die from certain broken bones, right? And so having triage robots that can be handling these kind of cookie cutter procedures, we need that. It's a matter of practicality. It's not an issue of whether or not there's patient acceptance or doctor acceptance. We're getting to the point where there's 8 billion people on the planet, and there simply aren't enough available practitioners in a local geographic area to handle not only just normal traffic flow, but mass shootings or dirty bomb. I mean, I don't want to get into dystopian kind of stuff, but
Sure.
Shit happens, right? Volcanoes, earthquakes. I mean, it's not just bad people. There's just nature stuff that happens, and it creates this massive burden on the healthcare system that we can't deal with as a simple HR problem. I can't just be like, well, we'll go recruit some doctors. From where? The roads are gone. Right? Yeah. So in those situations, you've got to be able to have some kind of technology that's going to be able to back up the practitioners and provide that kind of cookie cutter care. And that's gonna handle 80% of your use cases. And if 80% of your use cases can be handled um, by a robot or an automated system of some sort, well, then hopefully your actual human practitioners then can handle the remaining 20, 10 to 20% of your edge cases. That's what you got to build. That's what the market already needs it today. This isn't a future dystopia where, people don't get healthcare if we don't have this kind of technology. People aren't getting healthcare today because the systems are already overburdened and already unable to provide the kind of care that we need affordably, and when it's needed to all of the patients that are requiring it. And so we're already in a healthcare rationing situation. That's not just a United States thing, that is a planet thing. And so we have a need for this technology. There's no way that you can oversell. I mean, the hype around AI is horrific as it is, but in terms of the need, I don't think you can oversell the need and potential for robotics and AI, in healthcare. There's just it's the need is now. It is there now. The technology might not be mature enough, but we've got to get there. And there's no ifs, ands, or buts about it.
It segues me like perfectly to my next question, and this will be my final
Okay.
question. But like, how do you decide to place these medical robots, these surgical robots? And then I'm assuming, you talked about being a couple $1 million. That seems like that's a high barrier of entry. So part one of
Yeah.
the question is how many robots are in service right now? And how do you decide strategically to place them? And the third, I'm assuming you have limited production capabilities. You can't just be making millions of robots a year. So how do
Yeah.
you balance that, and how do you juggle that challenge?
It's a huge, huge problem that, I think if you solve, there's a Nobel Prize in it for you. Um, the the issue with surgical robotics in general, and this is a universal axiom, is no one solution solves all problems, right? The robot that can take out your appendix is not the robot that does LASIK for your eye.
Sure, sure.
And because just, you know, throw out a couple of just, little buzzwords, gear ratios alone. Like if I built a Da Vinci with the level of precision required for ophthalmological surgery, I am over engineering the Da Vinci just beyond, like, just to orders of magnitude beyond what is necessary to take out an appendix or to take out a prostate or hysterectomy or something like that. So there isn't one robot to rule them all. And
Right.
that creates a production problem, because that means, there's 170 robots on the market today. 8 of them do pedicle screws just for spine fusion, right? So even within a subsegment of surgery, there's a limited number of robots that will experience consolidation. So maybe we go from 8 to 4 over the next 10 years, but there's still 170 other robots.
Yeah. Yeah.
And so that creates a real interesting challenge there. And then the next one is, okay, Rosa's like 1.7 million. It's primarily a neurosurgery orthopedic robot. Da Vinci's incredible at abdominal surgery. It's 2 million and change. When you add on the accessories, 10% service model every year for break, fix, and maintenance. So it's like, oh my God, the numbers just add up. And
Yeah. Head
um, and
spinning.
then you have these little departments like ophthalmology or laryngology, where I can still benefit from surgical robotics, but I can't just, even if the Da Vinci was good for doing laryngeal or vocal cord surgery, your voice throat surgery department cannot amortize a $2 million robot over any period of time.
Yeah. Yeah.
You can't, it just doesn't fit the financial model. So you've got different robots that have to have different price points so that they can fit into different models. So that's a huge problem right there. And because of that, right now, most of your surgical robots are stuck in teaching hospitals where the weird Doctor Strange procedures are being performed. But that's not where the highest volume of procedures are being performed. So if I'm like Texas Spine Institute, I'm doing tons of back surgeries, right? These aren't weird, crazy use cases that are going to the teaching hospitals. These are I don't want to denigrate anybody's need for surgery by calling these run of the mill, but certainly they're not weird, case studies in spine surgery. They're relatively routine, which is why a group like the Texas Spine Institute can churn out, hundreds and hundreds of spine surgeries, a month, because they're bringing in patients that, just have, really the same kind of procedure over and over again. And that's great. But they've got high throughput requirements and they've got really tight margins. They're not a teaching hospital. So they can't financially justify any of the spine robots on the market today. So those spine robots stay at the teaching hospitals and the ASCs have no technology. And so what you really need is the next generation of surgical robots to have cost of acquisition models that aren't just CapEx. So we need to see, realistic lease to own models. We need to see SaaS models where I can place the robot. And if my robot costs $500,000 to build internally, placing that thing for free and making it up on per usage charges, that's a pretty burdensome thing for the company to do, right? So these are really challenging situations. So the next generation of robots, we need to see the price points come down. We need to see those robots require kind of the next generation model of navigation registration using actual vision, automatically registering to your CT scans and bone models and things like that. I can't spend 20 to 30 minutes touching fiducials and then tapping, confirmation on the touch screen to register the surgical robot. That's 20 to 30 minutes of OR time that is just I can't afford to do that in an ASC.
Yeah.
So we need to see the next generation of technology. That's AI, that's computer vision, that's integrating with visual systems, digital twins, right? So that's the whole next generation of software-based technologies. And we need to couple that with the next generation of low-cost surgical robotics. And fortunately, that is possible. A lot of, well, I mean, we've LASIK has blazed the trail, right? You used to need to, take a mortgage out in your house to get LASIK done, and now it's
Yeah.
like I can get it done at like the Walmart Eye Center. I don't know if they really do that yet, but LASIK has become incredibly accessible and affordable, and the technology has improved to the point where patients that were turned away as LASIK candidates 10 years ago, they're now like slam dunks. The software capabilities and motion tracking and all of those required technologies for LASIK have just gone through the roof. So the technology has continued to improve and the price point has come down. We need to see that throughout the rest of the industry because we need to remove the robots have to move out of the teaching hospitals or robots. I haven't looked into this in years, but I believe that the Da Vinci's market penetration is like 10 to 15%. If you had a company that was 20 years old, 25 years old, and you still were boasting that you had a 10 to 15% market penetration, right? HBR would be doing a case study on what a failure you are. And yet, Da Vinci's Intuitive Surgical is leading the field, right? They're the most successful ones, but because of the expense of that robot, they're stuck in the teaching hospitals. Good Sam, I think, is buying them. So there are some secondary hospitals, but the Da Vinci hasn't really been able to penetrate kind of that more, rural centers and things like that. I think they're getting there. But it's difficult because the price point is very, very hard to absorb at a lower volume hospital or a higher volume, tighter margin hospital, which is what an ASC effectively ends up being. So the economic challenges are substantial, and those need to be met. While at the same time improving their technology. So you need better technology at a cheaper price. It's not impossible. I mean, the iPhone and whatever your favorite smartphone is a perfect example of that. I mean, when I was a kid, Radio Shack literally sold a transistor radio that one of the big, graphics on the box was that it included 9 transistors. Why? This radio has 9 transistors in it. I think literally the Apple Watch is 1 billion transistors, right?
Yeah.
So that the technology of the transistor has become so ubiquitous that I don't even think, in fact, I'm looking at stuff on my desk and I'm like, transistor, transistor, I've got transistors in just everything around me. My desk lamp, I know for a fact, has multiple transistors in it. And so it's funny that that kind of technology has become so ubiquitous that we don't even think about it. And yet, when that thing was invented, it changed the world. And AI needs to do the same thing. Right now, we're stuck in the hype cycle with AI. AI needs to go back in the toolbox where it belongs. And you don't know that it's there because it's working. And I don't know if you know who Don Norman is. He had an emeritus position, I think, until he passed away at Apple, but he was at HP for a long time. And he was this big visionaries in terms of computing. And he always used to talk about the ubiquitousness of computing. And that's what we want to see, right? I've got smart bikes now, and that's obviously got a computer in it. It's like trying to figure out like what's the most efficient, energy to apply to my ability to pedal the thing and to give me a boost. That's driven by a computer. Do I care? Do I know? My microwave, that's got a computer in it. Do I care? Do I know? Computers are so ubiquitous that I don't even know that I'm interacting with one anymore. And if you think about like the early days of computing, that is so science fiction to conceive of, that computers would be so ubiquitous that I wouldn't even realize if I was dealing with a computer or not. That's what AI needs to do. We need to get AI out of this hype cycle where we're putting it in giant letters on the box, AI inside. And we need to get it to be so that it's so reliable, so functional that we don't care that it's there anymore, that it's
True.
just doing its job. Like, when's the last time somebody asked you, I don't know if you're a coder, but there's 20 different sorting algorithms. When's the last time somebody ever asked you which sorting algorithm you were using to alphabetize a list? Nobody
Never.
cares.
Yeah.
It
Yeah.
shouldn't matter.
It
Right?
doesn't.
Right. And so that's where things need to go. And so, right now, if you want to get a company funded, if you want to call your company a unicorn, it's gonna do you good to put AI on one of your slides. And it's just the nature of the beast. But AI is going to become most effective when we forget that it's there. And that's to me, that's Shangri-La, right? That's the Holy Grail. That's where we got to go. And that requires reliability. That requires an incredibly robust infrastructure. We've got to figure out the line between cloud computing and edge computing and how that makes the most sense. And it makes the most sense for medical robotics in a different way that it makes sense for diagnostics or for managing your EHR. All of those use cases have a different balance. We got to figure out what those balances are and apply them correctly and apply them transparently. And so that's kind of like that's my final sermon.
No, this conversation has been very insightful. It's been a learning experience for me. I
Oh,
mean, some of
thanks.
the stuff that you dropped is epic, and I haven't considered, and just learning about, like Galen and how you do what you do, and your thought process has been amazing and insightful.
Hey, thanks. Appreciate it.
So yeah,
Glad
yeah.
I could
Thank you
help.
so much. I will definitely be in touch. I think based on our discussion, let me see if I can end the recording. All right.
That's a wrap on this episode of Encrypted Ambition. Subscribe wherever you listen, and if today's guest inspired you, leave us a review or share the show with someone in your circle. To learn more about how we support innovators with AI, cybersecurity, and compliance, head to petronelatech.com. Thanks for listening, and remember, the future favors the bold.